So I am the lead for the policy research team. So our goal as a research team is to improve the level of evidence-based policy making in Australia. So Australian mental health policy is not really grounded in much scientific evidence. And so that's my team and I's goal, is to produce evidence that's really useful and digestible to policymakers. And our hope is that if we do that, then policy will reflect the latest evidence, and from policy come plans and programs. So actually what people will receive in the community, in hospitals, at GP clinics, in the psychologist's room, should slowly and surely reflect evidence-based practice if we can start from the top and work down.
Absolutely. And that's an intriguing sort of situation then. Prior to you guys trying to get evidence-based solutions, what were the government working on? What were they doing if they weren't using evidence?
That's a great question. So it's an interesting story. So my team and I's first attempt at doing policy-based research was actually to do an audit of the government's current policies. And we benchmarked those against the WHO, the World Health Organization's best practices for mental health policy. And the intended output from that was an audit and a set of recommendations. But when we went through, we realized that there was actually no evidence to audit at all. So it seems like a lot of the policy is based on partially what's sort of palatable to politicians and policymakers. Perhaps what the community might say what they want, and while that's really important, it also needs to reflect what's going to work for the community as well. And because of the way the sort of government system works, elected officials really need to look after and maintain relationships with their constituencies first, which are very diverse. So when you bring all of the Australian electorates together and try and make a policy that suits everyone, that's actually a real challenge. So the policies were reflecting a really diverse range of wants and needs, but not necessarily going back to the research and looking at the best way to serve those needs, if that makes sense.
Yeah, okay. Is there any pushback from the government here? It seems like this would be a pretty easy decision to make. Follow the evidence, obviously, but how's it all going? I guess it's government, so it's slow.
It's definitely slow. So I think sitting here at Black Dog, it seems like a really obvious choice to follow the evidence. I think for governments, it's actually a really difficult choice, because at the end of the day, there's just only so much money in the bank account. And mental health, we know, gets less funding in terms of service implementation, it gets less funding in terms of research, so that bank account is smaller than it is elsewhere. So the current government is really very interested in the evidence and very interested in evidence-based policy making. So that's good for us.
Yes.
We've got a relatively friendly audience. We've got Emma McBride, who looks after the mental health portfolio for the federal government, and she's very interested in the evidence and very interested in doing what's going to work for the most people. So that's a good thing at the moment. Throughout history, perhaps governments have been sort of slightly higher or slightly lower on their enthusiasm for evidence-based practice. So anytime you're doing anything in the policy space, you're really turning around a tanker. There's a lot of very established works happening and practices happening. And so it's a very slowly and methodical kind of process. So in the short term, there's lots of interests, but as you suggested, there is a slowness to it that is quite frustrating for an implementation-focused researcher like me.
All right, so I want to take it back a bit now, and I guess I want to start from the beginning. Peter Baldwin, he's just started university. What was it that sort of made you want to go down this side? Clinician, researcher. What was the first thing that came to your mind that made you want to do this?
Oh my gosh. Can I even remember back that far? So I was a very weird child, and I was a psychologist pretty much from birth. So I was very interested in how different brains perceive the world differently. So I noticed that people who were around me, like adults, would see things very differently, and not just their point of view, but they would actually see things like colours or distance or shape or weight differently. And I was very curious about why that was. And so all throughout sort of childhood and adolescence, I was very interested in how the brain worked. And then my mother bought me a book, which was a kind of a reflection from a mother of a young person who had schizophrenia. And that was kind of amazing to me. So for me, there was no other path. It was brains all the way. And so psychology was a sort of a natural fit. And initially I was very focused on research. And then I decided that I did want to be a clinician as well. So I was one of those foolish people who went all the way through and did all the degrees possible. And it took a really long time. But I think once I sat with particularly my first trauma patient, and saw someone recover from a really difficult experience they've had, and slowly not just recover from a mental illness, but really get their life back and be able to connect with their children and their partner, and go back to work and do all of those sorts of things that we take for granted. I think I was just hooked from that point. I just thought, this is a very special and privileged job that I get to do. So I've kept on doing it, and I've now moved from the clinical research space, which is really studying the best way to assess, diagnose and treat mental illnesses, sort of zooming out now with this policy lens and looking at, okay, well, how do we get a system working that can do that really well? That's my story.
Yeah, interesting. And so you said you started with the research and then wanted to do the clinician, and you think like combining the two like really helps getting, inside the clinic's room and also doing the research, that benefits the work you do?
Absolutely. I could never imagine doing one without the other. It was when I was doing my postgraduate studies, my academic supervisor said to me, I think you need to decide if you're a researcher with the heart and soul of a clinician or the other way around. Okay. And for me, I kind of took it as a challenge. Yeah. I thought, well, I don't think I should have to choose. Yeah. I want to do both. And a lot of people have told me that I'm very foolish, and I've learned along the way that it's probably not necessarily a sustainable model. But I love doing, so there's sort of like three facets of my job. There's the research, there's the clinical work, and then there's teaching. And I love doing all three. And so I try and make time for all three. And I think this is one of the wonderful things about Black Dog, is because it is a research institute, but we have clinics and we're also connected to the university. So there's an opportunity to sort of mix and match all three. And I think by doing all three, I stay connected to the needs and wants of mental health consumers by actually working with them in the clinic. I stay connected to best practice by actually having the opportunity to stay across the literature. And then I get the opportunity to take all of that and try as much as I can in my like nerdy lecturer way to inspire the next generation of clinicians to be very focused on those two. I'm not sure how effective I am at the third one, but I think I'm pretty good at 1 and 2.
I'm sure you're excellent at number 3 as well. Amazing. Okay. And then so once you finish university, you're now a clinician and you're researching at the same time. And I guess that didn't start at Black Dog Institute?
It actually did. So Black Dog was my first postdoctoral research fellowship. And I was a clinical psychology registrar as well. So I was a registrar in the clinics here. Nice. So I completed my registrar program here, and it's just sort of flowed on from there. So I started in digital mental health, which I was very interested in and still am. And then I moved, when the pandemic hit, into the mental health of health professionals. So that's when we opened our National Mental Health Service for health professionals. And that was myself and a colleague, Melissa Black, who we went to uni together and knew each other very well, which was very handy because there was lots of very early mornings and very late nights doing telehealth with very distressed health professionals. And then during the day, trying to work out how is this service going to work, how is it going to benefit the health profession nationally in the middle of a crisis. And so we're still doing some work in that. And then I moved into leading the clinical research team here for a while Professor Jill Newby was on maternity leave. And then when Jill came back, I sort of stepped in and set up our policy research efforts. So, it's been quite a journey at Black Dog.
What a journey indeed. And I know, like you were saying, you still believe in digital apps and stuff, and I know you work on the blended care model. Do we want to chat about the blended care model?
Yeah, absolutely.
Just put like an overview of what is the model?
Yeah, what is blended care? That's a big question. So in the digital health space, we spend a lot of time trying to work out how we can use computers and apps by themselves to help people with mental illness. And while there is a small proportion of people who do benefit from that alone, they tend to be in that very sort of mild stage of mental ill health. For people who from what we would really call a diagnosable mental illness and have more severe problems, digital isn't enough. The research is really clear that it's digital plus therapy. And those get really good results. It gets the same results as therapy by itself. And what it does is it actually frees up clinicians' time to do more face-to-face time with a diverse range of people, because part of the treatment package is coming from digital. So when people are learning specific skills or doing specific types of therapy, that's really good over in digital, and they can then focus their clinician time on other issues, things like family and relationship issues, trauma issues, all of those sorts of things. Very difficult to do in the digital space, but things like behavioural activation for mood, exposure therapies for anxiety, all of those sorts of things, they're reasonably regimented. So once the person's got a little bit of confidence in the clinic, we can give them a digital tool that will teach them how to implement that in their life. And so blended care is really a great way of bringing the two things that we know work relatively well, the digital stuff, really well, the face-to-face stuff, bringing that together and kind of supercharging that. And so our hope for the future is to see a kind of digital tool ecosystem where clinicians can think, okay, I've got time to see 10 people, I've got 15 people on my books. Let's take those 10 clients worth of clinician hours, split them up between the 15 people and fill those gaps with digital tools that we know are trustworthy. And so the data suggests that that's a really good thing to do and that will work. The barriers to actually doing it are not great digital infrastructure. We need to get better at doing that. We need to work a lot more with really good digital tool developers. As researchers, we like to think we can do all things. Researchers develop terrible apps and terrible websites, and we're not good at keeping them up to date or engaging. Yeah. So we need to bring all of that expertise in. And I think if we do that, we'll have a really good digital ecosystem, and we'll have apps that people actually want to use, which is very different from just using it because you're paid to be in a clinical trial to use it.
I know there's a long wait times to see psychologists. This would also reduce those times, hopefully, in the long run as well.
Yeah, absolutely. So we could potentially start care the second someone makes contact with the clinic. So they can actually get an onboarding program that's got some things that work for mild to moderate symptoms. There will be potentially, the clinicians might be free and have a schedule where they can do check-ins with people who are on wait lists. And then there's actually the other side of care. There's actually that discharge and keeping up, the gains that you've made during therapy. Yeah. That's a really good spot for digital as well. What we really want as cognitive behavioural therapists, as well as our goal is always for the person to become their own therapist while they're in therapy. And so really what they need then is kind of like a manual that's personalised for them. It's based on all of the things that they've learnt during therapy and that they know work for them, but they've got the references there so they can go back and go, okay, this is how I do that. Or when they're stuck, go back to a list of things that they know have worked, remind themselves, and actually have this guidance out there in their daily life. Rather than, it's very easy to do things in the clinic sometimes. It's very difficult to do it when you're, at work or you're sitting with your child when they're really upset or whatever the situation is.
Topic, are there apps that Black Dog put out now that maybe could start people in this blended care sort of model, just first steps type scenario?
So what we've worked on in the health professional space is, it was very interesting working with health professionals. They have a lot of very specific needs. There's a lot of stigma around health professionals seeking healthcare. So as a health professional, you're meant to be sort of like this impervious superhero type. And people don't really like it if you show any vulnerability. And it's not just patients, it's actually people in organisations, bosses and executives. Yeah. So what we did was really talk to them, listen to them and find out what they wanted. And we developed a program that was just addressing burnout. Health professionals don't like the word anxiety, they don't like the word depression, but they love the word burnout. Okay. So we tailored this burnout program for them that addresses all of the issues that they want. It addresses it in language that health professionals relate to. It's actually got content that is developed by and for health professionals. So we've got nurses, we've got doctors, we've got pharmacists, we've got physiotherapists. Actually, on this program talking directly to the user about their experience of burnout and how they recovered. It's available 24/7. It doesn't track any data whatsoever, so it's completely anonymous. And so when people come into our health professionals clinic, they get that first if they're on a waiting list.
Yeah.
So as soon as they come in, they've got something that is going to sort of start to give them tips and tricks and things to think about. And so by the time they see their clinician, often those symptoms of burnout that are really sort of that surface stuff, that emotional fatigue, the physical fatigue, that kind of cynicism, they've started to think about it and work on that. And so the sessions that they have with their psychiatrist or clinical psychologist, they can maybe focus on some of the underlying stuff, maybe problems at home, maybe bullying at work, maybe an assault that they experienced on the job that they're only just now ready to talk about. So I think that's a really good example of a Black Dog product that is perfect for that kind of waitlist period, but also that maintenance period afterwards. All the strategies are there and all the guidance are there.
Yeah, amazing. And that was the Essential Network, sorry?
Yeah.
10. Yeah.
Yeah, that's right. Yeah.
Cool. Amazing. And that was sort of developed in the wake of the pandemic, correct?
Yeah.
Obviously, healthcare professionals they already work on standard 12-hour days or something like that.
Yeah.
So I can't even imagine what the workload was during the pandemic. So
yeah, it's pretty horrible,
yeah,
to be honest.
Yeah.
And I think, what we were seeing is a lot of people, particularly in hospitals, that we already knew going into the pandemic that frontline health workers' mental health was bad. When we did cross-sectional surveys, we realised that it was actually worse than we realised. So there was, a really sizable proportion of the sample we had, which was about 8,000 health professionals that were experiencing sort of like moderate to severe symptoms of anxiety and depression. But when we looked at the burnout data, what we saw was they were like at the top of the scale, and it was actually about 97 to 99% of health professionals were at the top of the burnout scale, which was very worrying. We saw very worrying levels of suicidal ideation and lots of people reporting that they were either about to leave the workforce or thinking about leaving the workforce because of it.
Those are some scary numbers.
They were scary numbers, yeah. And I guess we just did what we possibly could do, which was, tailor-make a telehealth service that was private, anonymous and staffed by experts, make these digital products, have a web portal where people could come in, they could do self-assessments, they could get guidance on what help might be best for them at the time. And we tried to make it so people could access as much care 24/7.
Yeah.
And yes, it was somewhat successful.
Well, that's great. Well, as long as it's successful, we're on the right track, right? Okay, and so does the Essential Network work into the policy work you're doing with the government right now?
Yeah, oddly enough it does. So there's a lot of opportunity to work with the government on the Essential Network project, but also a lot of opportunity to work with peak bodies like the Australian Medical Association, the medical colleges, the Psychologists Association. And it was interesting because now I've got lots of contacts so I can get their perspective on how the mental health system is not working and how it should work. It was also a good opportunity for us to build a level of trust with the federal government to show that we can actually build and deliver something that does work and is useful. Yeah. So that was part of the piece, and another part of the piece is our really excellent government relations team that have built up these really strong relationships with people in government. Yeah. So we're in a phase now where we're somewhat victims of our success, where we're getting a lot of inbound inquiries from the government. They're asking us for a lot of help and support and a lot of guidance. Yeah. Which is actually really fantastic.
Yes.
But also, open dialogue is great. Slightly exhausting, but really, really, it's really fantastic that Black Dog is at so many tables in decision making when it comes to the Australian mental health system, because we do pride ourselves on bringing the best data. And the one thing that I notice when I'm sitting at those tables myself is it's just not a role that anyone else plays in that Australian landscape. We actually are the voice of mental health science in those rooms. And it's really, it's really needed and it's really appreciated as well, which is nice.
That's amazing. Well, I guess then let's look down the track. If everything goes well with the government policies we're trying to work in, what's say 5-10 years down the track, let's play the optimist. Where does this lead?
Hopefully it leads to better policies that reflect the best data, and that leads to the best outcomes for Australians. So what we would love to see is health services that are properly designed and delivered in a way that reflects and supports best practice. So when people go and they see their GP, they get a mental health plan and they go and see a psychologist, they're going to a GP that's got, the level of training and comfort with dealing with mental health that both the GP deserves and the consumer deserves. They're getting referred into a psychology service that is properly funded, that is, that the psychologists are properly trained and qualified to, deliver the types of services that consumer needs. Yeah. All of the data around that are being collected really well in a way that benefits the consumer. They don't have to tell their story time and time again. Benefits the clinicians. They've got really good, high quality assessment data, and it benefits researchers who want to go back and try and optimize that system as well. And so I think if we can get the policy pieces right now, I am confident that in 5 or 10 years' time that will flow down, and the government is very interested in looking at emerging technologies and how they can use that. So the government is interested in our AI expertise, and they are interested in our expertise around things like augmented reality and virtual reality-based therapies and making sure that they're supported, but also, our health informatics expertise as well, and thinking about data flow through the system. Okay, someone's at their GP. What's the how, when, and where of collecting data in that context? How should it move through the various systems? How should they communicate? And our goal is obviously to make sure that that happens, but make sure that it happens in a way that's still very human, that people aren't numbers or they're not data, they're actually still people, and also in a way that it's very invisible to them. That those technologies are sitting in the background and they're being very useful, but when someone goes to see their GP, they're not worried about being reduced to a number. They're not worried about being referred back to their smartphone for treatment, when actually what they really need is to talk to someone. And psychologists, psychiatrists, social workers, and other mental health clinicians aren't so overwhelmed by the technology that they fail to implement it, which is where we are now. It's a huge barrier to uptake.
Gosh, yeah. I mean, there's so many pathways to correct, treatment too. So it's so much for a GP to take on, so much. So, all I can do is wish you all the best.